later development in psychoanalysis, which led to ego psychology, basically didn't change anything on this fundamental fact that everything is being interpreted from postnatal event if we are dealing with psychologically determined disorders, because this doesn't apply to biologically or organically determined disorders. So the ego psychology then put a lot of emphasis on object relations and sort of refine the understanding of the interaction within the family and so on, the development of object relationships. But it shares with classical sort of Freudian analysis the fact that it's limited to biography. Everything that's not organic should be understandable from postnatal life. It's nothing of interest for psychologists that precedes birth, and that includes birth itself. Now, this obviously is very strange because of the intensity and the duration of the traumatization that occurs during birth. We are talking here about something that could be anything between an hour and maybe 50 hours of traumatic experiences where life is threatened. And this is not seen by traditional or new psychoanalysis as being psychotraumatic. And at the same time, the immediately following period, which is the early oral period, the nursing, is seen as something that can have tremendous relevance for the rest of the life of the individual, which of course is not a very logical way of approaching the problem. If the child didn't notice that anything strange was happening when it was being born, it will take a very long time before it can distinguish nuances of nursing or the way the mother is sort of treating and holding him or her and so on. Now, when we look at this, we'll see that the explanation in these terms is really incomplete. There are many aspects of these disorders that cannot be explained using this particular conceptual framework, and we'll explore it when we get to some concrete examples. It has been by and large accepted by the majority of psychiatrists for psychoneurosis and psychosomatic disorders. It was not seen as being completely convincing in relation to depression, where most psychiatrists would distinguish reactive depression, which can be psychologically understood, and so-called endogenous depression, which supposedly has some kind of unknown biological basis, where the psychological factors don't seem to be adequate or sufficient to explain what we are dealing with. And an absolute majority of psychiatrists found this absolutely unconvincing as far as schizophrenia or some major psychotic disorders are concerned. What I would like to show now is when we now approach these disorders using the large cartography that we are talking about and using the observations from non-ordinary states, that we get a much deeper, complete understanding of these disorders, and we also get clues about completely new treatment strategies that are not available as long as we think about these disorders in terms of psychoanalysis. So we can say now that there are, certain disorders that psychiatrists are treating which are truly organic. Those are primarily the so-called organic psychosis, where the current medical techniques, laboratory techniques, can really discover medical causes for these problems. Now, strictly speaking, these disorders really belong to neurology because they would be diagnosed by neurological methods. They would be treated by neurological methods. The reason why these people get to psychiatrists is because neurologists don't want to deal with the management problems in these patients. But strictly speaking, they're not psychiatric patients. So we're really left with a large group of people who have now emotional and psychosomatic problems, and we don't have any adequate medical explanation. Now, strictly speaking, we should not be referring to these disorders as diseases. They're not diseases in the same sense in which diabetes or anemia are diseases. For something to be a disease in the medical sense, this is referred to as nosological unit. Nosos means disease. We have to know something about the causes, about the etiology. We have to be able to understand how from these causes symptoms develop, which is called pathogenesis. We should be able to say something about the prognosis for this particular disorder, but particularly we should be able to use this rational understanding of the disease and develop a sort of appropriate treatment. Now, none of this is really the case in these sort of psychiatric disorders in the narrower sense when we exclude the neurological cases. We'll certainly try to do diagnosis, which is something very important in medicine. In medicine, the success of treatment will critically depend on the correct diagnosis. If I make a diagnosis, somebody who's a better doctor than I am can show me that my diagnosis was wrong, and that for that reason my therapy is not appropriate. Now, that situation is very different in psychiatry. In psychiatry, if we take a patient and let the patient be assessed by 10 psychiatrists, it's very likely that they will very vastly diverge as far as the diagnosis is concerned. Different countries have different classifications. The French classification is very different from the Australian and from the American and so on. But what is even worse is even if the psychiatrist would agree on the diagnosis, it doesn't commit them to any kind of specific treatment, which is the case in medicine. So we find, for example, psychiatrists who would be giving electroshocks to neurotics, and we found psychiatrists who would be doing psychotherapy with psychotics. So the diagnosis that we make has really no direct relevance for treatment, which is the situation in medicine, of course. So we shouldn't really talk in psychiatry about diseases. And if we would sort of push hard, psychiatrist, he would have to admit, or she would have to admit, that what we treat are not really diseases. We think about these things in terms of symptoms and syndromes. Symptoms are certain fundamental building blocks of emotional disorders, such as anxiety, depression, obsessive-compulsive problems, and so on. And then syndromes are certain specific clusters of symptoms that we see frequently. And what I would like to show now is how we get a much, much deeper understanding as to why we have certain symptoms in psychiatry and also why they cluster in these particular syndromes. And I would begin with anxiety, which I think most psychotherapists would consider to be the most fundamental symptoms. A lot of patients who come to us have either free-floating anxiety or they suffer from different phobias, or we can show that many other symptoms are actually ways of dealing with anxiety or bind the underlying anxiety. For example, patients who are obsessive-compulsive, if they try to suppress their obsessions and compulsions, they start experiencing anxiety. Now, Freud himself saw anxiety as something related to sexuality, to the libido, something that comes from repression of libidinal impulses. If we are repressing our libido, we start experiencing anxiety. Now, there was a problem in this definition because the major way of suppressing sexuality is through emotions, and one significant emotion that can do it is anxiety. So we have anxiety coming from repressed libido, but also anxiety is one of the significant factors that are involved in the suppression of the libido. Freud wasn't very satisfied with it, and actually for a short period of his life he toyed with the idea that maybe all anxiety can be traced back to the anxiety experienced by the child during the passage through the birth canal. He actually was pointing out certain linguistic connections, that in many languages the word for anxiety is closely connected to narrowness or narrow passage. He specifically mentions in Latin anxiety is anxietas, and it's related to angustie, which is a narrow canyon. In German we have, for example, Eng is narrow and Angst is fear. In some of the Slavic languages like Russian or Czech, there's actually the same word used for anxiety and for narrowness, something narrow.